Welcome, everyone. My name is Jessica Shortall. I'm the strategic partnerships lead for our Healthier Communities team here at R Street Institute. And I'm really excited to, even just for myself, be here and learn from our two panelists and have a discussion about an issue that we think is really urgent, that close to my heart and I think is really important, which is the confluence of HIV and smoking. Just a little overview. Americans living with HIV now lose more years of life to smoking than to HIV itself. And some of that is a huge success story, right? It's the decades of activism and advocacy and science that led to the transformation of HIV to a chronic and manageable condition. But it's also a really frustrating example of some folks being left behind in the big success story of reduced smoking in the United States. So cigarette smoking among the US adults is now below 10% for the first time that we've ever recorded it, which is fantastic. But people with HIV still smoke at up to 4 times that rate. Many want to quit smoking, but quit rates are much lower than the general population. And people with HIV tend to have worse outcomes when using the traditional quit smoking methods that you might think of, like counseling and medication. Excited to talk with our two panelists today and hear from them about what we can do about this, kind of area of smoking that's standing in the shadow of the achievements around HIV, about the overlapping and intertwined challenges that people with HIV face, including mental health, stress, discrimination, poverty, substance use, and what those layers mean to reducing harm and even, quitting smoking. So I would love, because you all are so accomplished, I don't want to leave anything out, if you would both introduce yourselves briefly. So we'll start with Trish.
Thank you very much. Hi, Jessica. Good afternoon, everyone. It's a pleasure to be here, and thank you so much to Jessica and R Street Institute for inviting me to participate in this panel and for organizing this event. So, as Jessica said, my name's Patricia Cioe. I'm currently a professor and associate dean for research and scholarship at the University of Rhode Island College of Nursing. I'm a licensed certified nurse practitioner in the state of Rhode Island for the past 20 years, and I've spent my clinical career since 2001 providing care to people living with HIV. So before I joined the University of Rhode Island, I spent 13 years at Brown University School of Public Health, where my program of research focused on tobacco dependence, smoking cessation, and tobacco harm reduction. Most of those studies involve people living with HIV because that's where my clinical practice has been focused. And at the University of Rhode Island, my work is continuing in this area. Thank you.
Thank you. Lauren, over to you.
Hi, and again, just want to echo what Trish said. Thank you to Jessica and to R Street for organizing and for inviting me to participate. Really glad to be here. So I'm Lauren Pacek. I am currently an assistant professor at the Rutgers Robert Wood Johnson Medical School in the Department of Medicine, as well as the Rutgers Institute for Nicotine and Tobacco Studies. I am an epidemiologist by training, but also have experience in clinical trials and intervention development research. I've been doing research among people with HIV for like 13 years now, more than 10 years, we'll say. Um, and a lot of my work really is, has sort of an epidemiological focus given my training, but I also have experience with developing interventions for smoking cessation in this population, um, specifically developing mobile health interventions to try and help people with HIV to quit smoking. And I am really trying to sort of resurrect that area of my research. I had been doing it when I was on faculty at Duke, took a small break from academia, and now that I'm back, really trying to resurrect that. So that's me.
Oh, I'm trying to check to make sure I'm not muted. Wonderful. Okay, thank you both. And thank you for the work you do. It's so important. So yeah, I mean, decades, cumulative, many decades between the two of you of working with and caring about people with HIV. Can you talk about, both of you, about the barriers, the complexity of barriers to smoking cessation that you see among this population? what are the overlapping factors that you see impacting folks?
Sure. Trish, do you mind if
No, go ahead.
I'll tag you in? Yeah,
Okay.
so I think that, there are a number of barriers, both at sort of the individual level, so within the patient with HIV, that serve as barriers to smoking cessation. There's within patients with HIV, there's a lot of substance use and mental health comorbidities that, of course, are on their own associated with higher rates of cigarette smoking, but also associated with greater difficulty in quitting. This population also faces a number of stressors, both sort of just generalized life stress, HIV specific stress, sometimes things like poverty, discrimination, and stigma also serve to hinder smoking cessation efforts. Um, Beyond the individual level factors that impede cessation, there are also things like things at the HIV healthcare provider level that might serve to, um, I'm not saying stop people from quitting smoking, but, that kind of get in the way, where, by just the nature of a clinical encounter, they're time limited. And as Trish, I'm sure, can speak from personal experience. Like, you only have so much time to address, uh, even like the presenting issue, let alone things tacked on to the end. So there's, not a whole lot of time. People are often not trained or don't feel confident in providing these sorts of services. So there's a number of levels of factors that are kind of working against people with HIV.
Yeah, I can just add to that a little bit. So we conducted some qualitative interviews. I published a paper in 2018 where I specifically asked patients living with HIV, 25 of them that were currently smoking or had previously smoked and had recently quit. And so we learned several key things from them about their barriers to cessation. And there were five themes that were identified. So one of them was a high level of dependence. People with HIV smoke quite heavily. They often smoke within the first 30 minutes of waking up. They smoke a high number of cigarettes per day, and they've been smoking for many years. So if you look at any of the studies where I've developed interventions, the mean years of smoking is often 25, 35 years. People have been smoking for a very long time. They started in their teens and it hadn't been addressed. And some of that is related to that whole history of HIV. There was a certain amount of fatalism where they thought, oh, I now have HIV. I probably won't even live very long. So there's no sense in quitting smoking. So they kept on smoking. Along the years, they've made many quit attempts, but they're often unsuccessful. Another theme that emerged was that smoking is a form of stress management. And as Lauren mentioned, there are many stressors. A lot of them are dealing with poverty, stigma, social isolation. There are so many stresses in their life. And they say that they smoke in order to manage their stress. So that's a key concern. Another theme that I was identified was they have low confidence. They've tried quitting so many times. They have low self-efficacy. They don't believe they can quit. I have quotes in that paper that say, I've tried so many times and can't and haven't been successful. I just don't think I can quit. And then surprisingly, something that was surprising to me was there's a certain number of patients with HIV that have ambivalence toward quitting. They say, I've
Mhm.
given up everything else since I was diagnosed with HIV. I'm just not giving up smoking. It's not something I want to give up. And they enjoy smoking. So, yeah, so that's something we need to address as well.
I think that's such a good point, all of these, but that, in we hear this a lot, and it seems to be broadly accepted in public health spaces that people who use other substances, people who use drugs, for example, that while that use may be detrimental to their health and well-being, that they're doing so for real reasons.
Right.
And that's where the kind of harm reduction ethos comes in the space of supporting people who use drugs is you have real things going on in your life. This is a coping mechanism. This is something that gives you relief or joy. if it's harming you, let's try to figure out how you can reduce that harm. And I think sometimes we just have this like widely accepted social stigma, public stigma about smoking in a different way where we forget that that's true in that space too. And your point too about like fatalism, especially folks who were diagnosed, before this condition was effectively transformed by advances in treatment. So like, well, I mean, I sort of sometimes connect it in my mind to the high smoking rate among veterans, especially
Mm.
deployed folks who have been deployed. Is like if you're we talked with a veteran a few months ago, a year ago, here at R Street, who was saying, like if you don't know if you're going to make it through that day, why would you not have a cigarette? I mean, you need to cope with that stress somehow. So I think recognizing that is such an important part of um, helping people who do want wellness um, to make their own path toward it. And then also
Yeah.
just wanted to note like these mini quit attempts. I think of our good friend Skip, who I think is dialed in and watching the call. I remember Skip telling me years ago that she had tried to quit so many times that she didn't want to try again and be kind of reinforced. So Skip, I hope you're okay with me sharing this story and have that reinforced yet again, like, oh, I couldn't do it again, is that's a really difficult thing to do. And
Yeah.
something we can all, whether we've tried to get on an exercise plan or make other changes in our life, like I can certainly relate to that. So anyway, that's really great framing. And
I
Skip
just want to
also found her
mention
own harm reduction path. So I think that she's a wonderful success story. Sorry, go ahead.
one of the no, I was just going to say one of the thing that I wanted to mention, it didn't surface in our study, but I've done a lot of reading about it, especially lately, is that loneliness is a key theme that I've heard in my clinical practice, and I've done a lot of reading about. It's especially prevalent in people with
Mm,
HIV. So there's a lot of social isolation. There's a lot of stigma
mm.
related to HIV still. And so people with HIV, there's a 60% prevalence of loneliness in this population. And it's been shown that people who are lonely have higher rates of smoking and they also have lower rates of cessation. So I think that's something we need to think about when we're designing intervention as well, that people are really lonely.
Mm. There's so many parallels because we talk a lot at our street too about older folks and smoking, which of course the population with HIV I think is trending older over time, right?
Yeah.
But there's loneliness and social isolation that, surgeons general have talked about as societal problems, and we do see, high smoking rates among older folks generally too. Okay, so given the urgency of the problem, given that, we see it, I think people sometimes don't think about smoking as an urgent problem because the toll happens over decades rather than today. But I consider that urgent. Almost 500,000 Americans still die from smoking related causes a year, so that seems urgent to me. Can you both talk about the spectrum of beneficial changes that you might see a patient or a person take, whether that's, reduction, abstinence via traditional methods, any harm reduction approaches you're taking, education that might change the way people think about, what are the potential ways that people could incrementally improve their wellness as it relates to smoking?
Sure. So I think the first thing that you mentioned was that, sort of reducing the number of cigarettes that one smokes per day. Um, and yeah, there certainly is some research to show that lighter smokers have reductions in lung cancer mortality. So yeah, that can be, I think, a really great sort of first step. I tend to think about reducing cigarettes per day as kind of like an intermediate step. Like it's great. It's a great first step to take in light of, reductions in cancer mortality, but also, sort of keeping in mind at the same time that there's also research showing that reducing the number of cigarettes that you smoke per day doesn't really confer um, cardiovascular benefits in the way that you hope that it would. So it's kind of a mixed bag. But I think also research shows that reduction over time can lead to quit attempts and then cessation. So I mean, it should be encouraged. It's a good thing.
I mean,
Um,
back to that sort of feeling of, I failed at quitting. I can't. It might be a
yeah,
more achievable goal.
yeah,
that leads to that kind of ultimate desired outcome of cessation. Yeah.
Absolutely.
Yeah, I
Baby.
was going to say that it may be more amenable, patients may be more amenable
Mhm.
to that type of approach. They don't want to just set a quit date and quit completely on a certain date. But if you talk to them about, I would very often say to them, why don't you start by one cigarette per week? So today you're smoking 20 cigarettes a day. All next week, smoke just 19 per day. Take one out of every pack, one cigarette. And then the following week, take two out of every pack. So, reducing by one per week. And they always seem to be more amenable to that. It seemed
Mm.
very achievable, taking those small steps.
And that sort of sounds like it goes back to your comment about folks saying, I've given up so many other things. I'm not going to, there's like a sort of a understandable stubbornness about something that brings you relief or a break in the day or whatever. It's like, don't make me give up everything. So this is like, I'm not. Let's try one. Let's try one. And this is a very prevalent conversation in drugs and harm reduction is this like any positive change, self-directed
Yeah.
thing is a great way to help people build that sense of autonomy and making their own choices.
I
Um,
think take I think taking those small steps too can build their confidence.
mhm,
They can see success week by week. Like, oh, I gave up one. I didn't think I could do that. Oh, I gave up two. So those small steps rather than making major behavior
mhm.
changes.
Right. And what do you all see in the kind of more traditional, what most of us would think about for smoking cessation or reduction? So nicotine patches and gums, medications, behavioral therapy, counseling, text lines in specific to the populations you support and work with, people with HIV. How do those land? Are they working?
Sure. So, let's start with nicotine replacement therapy. I didn't realize this until I was putting in a grant in beginning of this month, that there are actually no studies among people with HIV of nicotine replacement therapy alone, evaluating the effectiveness. It's always nicotine replacement therapy coupled with a behavioral intervention. But that said, we know that in the general population that nicotine replacement therapy is effective, particularly whenever you combine like a the patch with a short acting like gum or lozenge. Um, it's very effective. And I know that nicotine replacement therapy is safe and well tolerated for this population. Um, so there's that. So there's not the like, necessarily like NRT alone is effective. Um, in terms of other, and if I'm thinking about just FDA approved smoking cessation medications, we have bupropion and varenicline. I think that there's relatively less work looking at bupropion, which is Wellbutrin or Zyban, among people with HIV. In the general population, it's effective, but there are some drug-drug interaction concerns for people with HIV. The concentrations of bupropion might be reduced whenever people are on antiretroviral drugs that are CYP2D6 inhibitors like ritonavir. So it's just a consideration. Um, but varenicline, on the other hand, it's safe and well tolerated among people with HIV. It's effective for cessation. I think that we have probably the varenicline has a really nice evidence base in this population at the moment. There's no evidence of drug-drug interactions with ART meds. Um, it is metabolized in the kidneys, so it might not be a great fit for people with HIV who also have kidney disease. Um, One thing that I do want to note about these pharmacological cessation interventions, and Trish, I'm sure that you see this clinically, is that adherence to these medications, I mean, it's an issue kind of like for smokers broadly. Adherence is not great, but adherence is an issue for people with HIV. And we all know that not if you don't take your medication like you're supposed to, it doesn't work like it's supposed to. So I think that there's a lot of room for improvement in this population. If we can incentivize adherence to these medications, I think we could probably boost cessation rates. But
Yeah.
Yeah, I think that adherence is at least part of the puzzle, like accounting for why we're seeing lower quit rates among people with HIV.
Yeah, I'd like to speak to that for a minute. So, adherence is definitely an issue that's been seen in many of the clinical trials. It's not what it should be. I think a couple of things are related to that. Something I think that's prevalent in the HIV population is treatment fatigue. You know, these are people that are
Hmm.
taking, they often have complex medical regimens. They're taking lots of pills daily. And I know that HIV medications, you can take one pill once a day now, but many of them have the history of taking up to 16 pills a day. So they're taking one pill a day for their HIV, but they also may be on medications for depression or anxiety or hypertension or diabetes. There's a high prevalence of diabetes in this population. So they're taking lots of oral medications. So very often when I would talk to my patients about, medications for smoking cessation, they preferred the nicotine replacement therapies because they weren't oral. They didn't want to
Hmm.
add another pill to their complex regimens. So that's one
It's
factor.
exhausting. It's
Excuse me.
exhausting to
It
sit
is. I mean, it's
down
called treatment
and look at the
fatigue.
pills and
Yeah.
yeah, yeah.
So they're tired of taking pills every day. So when you talk
Hmm.
to them about adding another pill, it's like, no, I'm not doing that. But will they try patch and lozenge or patch and gum? Sure, they will. But there's also a lot of fear around adding another medication. So one of the things we did in one of our clinical trials was during our nurse counseling sessions, we had them put the patch on in the counseling session at the beginning, right when they were with the nurse. That way they were going to spend 40 minutes with the nurse and have that patch on for 40 minutes while they were sitting with the nurse. And that helped relieve some of their anxiety about trying something like patch. There's still so many misperceptions about the patch and whether or not it's going to cause you to have a heart attack, which is what I heard so many times in clinic. So little things like that may help reduce the non-adherence in the population.
I love that. Just like those kind of little tweaks to try to address some of those fears.
Yeah,
Um,
yeah.
Lauren, I stumbled upon your work when you were giving a presentation online, and one of the things you talked about was lung screenings as a tool to kind of help drive change. Can you talk about that?
Yeah, sure. So I think I said this in that presentation also, but whenever you think about sort of like harm reduction techniques for tobacco use, I think about like transitioning people from cigarettes or combusted products to something less harmful. But I read a paper, I think Jonathan Shooter is the first author, where he described lung cancer screening as a harm reduction measure, specifically for people with HIV who smoke. And I would like blew my mind because I'm like, oh yeah, of course, this is absolutely a harm reduction technique. So in the general population, the American Cancer Society recommends annual low dose computed tomography screening for smokers who are at high risk. And this is just a CT scan. Um, it takes only a few minutes. Evidently, there's less radiation exposure using this technique versus like a standard CT. Um, and you don't need to like get any injections beforehand. There's no preparation. You just get in the machine and off you go. Um, and this is an important tool because meta-analyses show that getting this lung cancer screening triples the odds of detecting lung cancer at an early stage. And maybe it's at a stage where it's small enough that it can be removed surgically and reduce the need for radiation and chemo afterwards. And it also significantly reduces lung cancer mortality. So it's great. This is a wonderful tool that we have available to us. Right now, guidelines say that if you're between the ages of 50 and 80 and you have a 20 pack year or more smoking history, and you're a current smoker or you've recently quit, you should get screened. But it's really underutilized among people with HIV. And I mean, it's problematic generally, but also because people with HIV tend to acquire lung cancer at earlier ages and with lower lifetime cigarette exposure than the general population.
Mm.
And independent of smoking, HIV is a risk factor for a number of smoking related cancers. So it's not being used, but it has the potential to catch cancer early.
And
Okay.
survival rates are higher when it's caught early, as you
Yes.
mentioned. So,
Yes.
yeah.
Is there like a psychological impact or a sort of motivating factor once people do get that screening to understanding this, what your lungs look like? This, we can still do something about this. Do you see any of that?
So I'm not sure about that. I know that there is one study showing that people who underwent this screening, I think maybe like 20, it was like 20 to 25% of them ended up quitting smoking as a result. So I'm not sure what like the mechanism in between the screening and the quitting was, if it was that sort of, you know, psychological change after seeing
Sure,
what,
sure,
yeah.
sure, sure.
I don't know if Trish can speak to
Yeah,
that
I
as a
can tell you
clinician
that I
or.
haven't had many patients that have either agreed to do the screening or have had insurance that would cover the screening. It's kind of interesting that even though this is what's recommended, very often insurances would deny approval of the CAT scan. So it's an unfortunate reality of our third-party payers in this country.
Mhm.
Indeed.
Okay. All right, let's circle back to nicotine replacement because I realized I wanted to ask another question. I think we have a pretty highly informed audience on this event and folks that will watch it after the fact. But you mentioned, Trish, some misconceptions about the safety of nicotine. People have concerns about heart impacts on heart, but could both of you just talk a little bit about the distinction between nicotine and lighting tobacco on fire and inhaling the smoke, um, and what other misconceptions you see and hear among this population?
Yeah, so it's interesting because I think there was a study that was just published showing that a number of healthcare providers and also a high percentage of the public believe that nicotine causes cancer. And that's a very strong misperception because nicotine
Hmm.
doesn't cause cancer. So it is the combustion of tobacco that's actually the cancer causing, that causes the toxins that are related to cancers. So combustion refers to lighting up a cigarette. Nicotine, on the other hand, is medicinal in nicotine replacement therapy. So it is related to cardiovascular effects. So nicotine will increase someone's heart rate, it will increase their blood pressure, and in that way can be related to cardiovascular concerns. However, it's not related to cancers. Um, did I answer your question?
Yes, very much so. Yeah, I was
Okay,
pausing if you
okay.
wanted to add anything else. And you've both said that NRT nicotine replacement therapy can be effective. Like to what roughly percent of what kind of quit rates are we seeing using those tools?
Ooh, I should know this
Yeah,
offhand, but I don't.
you know what? I just looked that up right before we met today. So one of the Cochrane reviews shows that nicotine replacement therapy increases quit rates by about 10 to 25%. So
And we don't have data specifically on people with HIV in that
Mm,
space.
I don't think so.
I don't
No.
think.
Okay, so then let's talk about some of the other approaches. And these aren't mutually exclusive, right? There's a layering. So we talked about medications. Let's talk about behavioral counseling. Is that a useful tool on its own? Are you seeing that useful with the folks that you support? Are there unique considerations around behavioral counseling regarding people with HIV who smoke?
I'm not sure there are specific considerations with regard to behavioral counseling, with regard to people with HIV. I think it's been shown that it's effective when used with medications. Certainly, medications plus behavioral counseling is very helpful. Helping people to understand how to manage cravings, that's something we
Mm,
address in counseling, really important. Especially when you're using combination nicotine replacement therapy, understanding that the patch is giving you more of a low dose of nicotine throughout the day, but then the gum or the lozenge can be used to manage cravings on a very regular basis throughout the day is very important for them to understand. So I think there's a place for both medications and counseling, and you see your best cessation rates when you're using medications in combination with counseling. I don't find that counseling is all that effective on its own. And I think their literature would support that nicotine is a highly addictive drug. People develop dependence on nicotine. So you really need to use a medication that will somehow relieve that
mhm.
dependence and those cravings related to withdrawal of that addictive drug.
And that category, when you say medication, you mean both the FDA approved medications and nicotine replacement therapy
Replace,
products kind of in
yeah,
that
which is
bucket.
also
Yeah, yeah, yeah.
FDA approved. Yes.
Yeah,
Yeah,
yes.
the full
Yeah.
spectrum of all of the medications. Yeah.
Yeah, we've had past panels and discussions where we've had people on who used illicit drugs for many years and smoked for many years and ta and have said it's, anecdote, but that nicotine was the hardest thing to quit.
Mm.
Or that, I've quit
Yeah,
everything else. I got to hang on to nicotine in one way or another. And so for both,
absolutely.
it's tough. It's
Yeah,
I
I
think we
had a
have a kind of cold turkey narrative, like just try harder, but it's really hard.
Yeah, for about 8 years, I was very involved as the manager of a outpatient opioid treatment program. And I had many patients tell me that stopping nicotine is more difficult than stopping heroin.
Hmm.
So,
Yeah. Right. So this like kind of layered approach makes
yeah,
sense,
so
right? We want to kind of give
it really
different tools.
speaks, yeah, it really speaks to the addictive nature of nicotine.
Hmm. And I mean, we talk too a lot about the sort of chemical aspect of that addiction, but also actually Skip noted something in the Q&A, a question I'll just throw in here now. Do you see people who are lonely viewing their cigarettes as their friend? I asked because one of the people in one of my peer support groups referred to cigarettes as her friend. That took me by surprise until I sat down and thought about all the parts of my life's journey where cigarettes were with me every step of the way. Um, so there are those kind of social and emotional aspects of that dependence that go beyond the sort of chemical um, nature of nicotine. Did you all see that as well, I'm guessing?
Absolutely. And I've heard those exact words said by my patients that the
Huh.
cigarette is my friend. Yeah,
Hmm.
absolutely. It may be in the paper as one of the quotes, but absolutely. Yeah, we've heard that. And so
I have
there's a certain
I don't have
comfort.
my hands on the link to that, but if you have a moment to throw it in the chat, it'd be super great. I'm sure folks would love to see it
Oh, for
at,
that paper,
at
yeah,
whatever point.
sure, I can pull that up. Um, yeah, I was going to say that, there's some level of comfort that comes from sitting with something that's known and having that cigarette. And
Hmm.
so I think that is one of the reasons too why I did some work around harm reduction in an electronic cigarette because we wanted
Hmm.
to remove the products of combustion, which are the cancer-causing chemicals, but we didn't want to extinguish the behavior, which is
Uh-huh.
the philosophy behind harm reduction, because we knew there was a certain population that said, yeah, I do want to continue this. It is
Yeah.
my friend. I enjoy it. It's just a behavior I enjoy. And so we thought, how can we make it safer by and also maintain that behavior for the patient?
Right. I mean, I think if we can, it's hard, set down our specific stigmas about smoking, many of us can relate to that. I really like having a glass of wine while I cook dinner.
Mm.
Yeah.
That's a friend to me, right? And then there are days where I'm like, I probably shouldn't do that. What can I replace this with? And rather than just taking it away, I will pour myself a glass of kombucha and see how that goes. Like maybe that is it still tastes good. It's something I can sip on while I cook. And so I still get to do the behavior. So anyway, it resonates with me a lot for sure. So then let's talk about, it's a great segue about these products out there, e-cigarettes, nicotine pouches, and both of your work investigating this space, the pros, the cons, the nuances you think about. So first of all, let me ask, what do we know about these products and what still is sort of be under investigation or remains to be understood and determined about these products and how they impact people?
Yeah. Thinking about e-cigarettes specifically, I mean, I think the jury is still out on the long-term health effects of these products simply because they haven't existed that long, for that long of a time. And, these sort of like chronic tobacco-related conditions take decades often to emerge. So I think there just hasn't really been enough time to speak to like really long-term health effects of e-cigarette use. However, we do know that they are like orders of magnitude less harmful than combusted cigarettes. If you look at studies comparing like biomarkers of exposure and biomarkers of potential harm between people who use e-cigarettes versus combusted tobacco products. Like it's not that e-cigarettes are without harm. It's just so much less than combusted products. Yeah. So I'll stop there. That's for e-cigarettes, I think that's sort of where we are at the moment. Nicotine pouches, a lot less is known, again, because they just came onto the market several years ago. Um, Logically, if you think about it, if it's the products don't contain tobacco leaf, they are synthetic. I think all of them, or most of them, they contain synthetic nicotine, so like lab-derived nicotine rather than tobacco leaf-derived nicotine. Um, so you're eliminating a lot of the exposure to carcinogens. So they also should be much less harmful than combusted products. But I suppose time will tell ultimately.
Yeah, I often like to say that are electronic cigarettes safe? No, they're safer.
hmm
So it's definitely a continuum of risk, which has been published and promoted by the FDA. So there's a continuum risk where we have combustible tobacco that is the most harmful product on the market. So smoking cigarettes is the most harmful. Never starting to smoke is the best option. If you never start smoking or never start using electronic cigarettes, that's the most healthful thing to do. But along that entire continuum, there's a continuum of risk, increased risk depending on the products. Electronic cigarettes, nicotine pouches, any of those non-combustible products are lower on the continuum of risk compared to combustible tobacco. So while they're not considered safe, because as Lauren said, we don't know long-term effects, they are safer because they don't involve combustion.
Mhm. Right. And when we're talking about people who already smoke, like, of course, never starting is
Right.
the
Exactly.
most helpful thing to do, but we are where we are.
Right.
Um,
And
uh,
in any of my studies, as I mentioned, people have been smoking 20, 30 years. So if they're not willing to quit, or they're not able, they feel they're not able to quit, then electronic cigarettes may be, or nicotine pouches, a switch may be a very viable alternative. And it may be something they're willing to try.
you are segueing beautifully. So I was going to ask you next, can these methods help people who struggle with everything we've talked about already, this kind of suite of more traditional, and people who do not want to quit? And like, at what point do you introduce that concept to folks? Is that first line, or is that let's try these other things? Is it very, individual specific of whether or when you're saying, okay, well, here's this option?
Mm.
I'm thrilled you asked that question because we have a paper that will be coming out in the next month or two, which I will just speak to generally. But what we are doing is actually talking about electronic cigarettes and providing sort of counseling advice. And this was a group from the Society for Research on Nicotine Tobacco. I think there are 25 of us that are have written this paper, and it will be published hopefully in the next couple of months. And what we are actually saying is that someone does not have to fail traditional smoking cessation medications. It should be a menu of options. And electronic cigarettes, nicotine pouches, we're specifically talking about e-cigarettes in the article, not pouches, but they should be part of that sort of armamentarium of what you're offering to patients. So patients should be given a complete menu of options. This is what you could try, and electronic cigarettes should be part of that conversation. So should
Got
they
it. So
be
this is
first
not a
line?
staging thing
Right.
of
We
like,
don't
we've
see it
tried all
that
these.
way.
Now I will kind of reluctantly bring this up. This is,
Exactly.
mhm.
Exactly. They
And
don't
here's the
need to
benefits and
fail.
risks to each of these things. And, what do you think will work for
Absolutely.
you? Yeah, yeah.
Yeah, absolutely. Include those in the conversation.
What about you, Lauren? What's your take on this?
No, I mean, I wasn't aware of that paper being written, but I'm excited to see it whenever it does come out.
It's
But oh, go ahead, sorry.
it's a great paper.
Well, I'm
So,
excited
not
to read
because I
it.
was involved, but it's a
We
great
will,
paper. I'm very
when it comes
excited.
out, we'll send the list of attendees. We'll send it out.
Okay, great.
But not that I'm not in a clinical sense providing tobacco treatment recommendations, but I'm of the same mind
Mm.
that yeah, it really, like Trish said, a menu. Like these are all of the potential options, and we sort of work with a patient to identify what is the best fit for them, what they're most willing to use, rather than, if you fail the traditional methods, then I guess we'll, yeah,
Hmm.
include the harm reduction methods too.
So there aren't situations where you'd stay away from talking about this as an option for people, or are there?
Um,
Not to lead the witness.
yeah, I don't think so. I think I would include it in most, if not all, conversations with
Mm.
patients um, about either quitting or switching. So I think if someone had had a recent cardiovascular event,
Mm.
I would be somewhat concerned and I would voice that concern to them because some of the electronic cigarettes have very high percentages of nicotine. And so I'd be concerned about exposing them to more nicotine because it is a cardiovascular stimulant than they might be getting from their cigarette. But we also know from studies that people tend to self-regulate. So they're used to receiving a certain level of nicotine. And when they switch to an electronic cigarette, although it may be more potent, they sort of self-regulate how they use, and their serum blood level of nicotine doesn't change all that much necessarily.
Hmm.
So I think that
Interesting.
would probably just be something I would talk with a patient about.
The other thing I think is interesting is, we talk about these like positive steps, like reducing from 20 cigarettes a day to 19 or, what have you, that those are positive things. There is kind of a tension around that any positive change mindset and some of the research around the benefits of completely switching to a e-cigarette or nicotine pouches or whatever versus dual use. Um, and there's some real tension there because I think, what you would want clinically, to correct me if I'm wrong, is to see a complete switch.
Yes.
Um, but is that an immediately achievable goal? Is that a goal you can communicate that we'd love to get there over time? Is it a step-by-step thing, or do you take that on a case-by-case basis about how you talk with folks about that so it feels approachable, while keeping in mind that, the evidence shows that that's the ideal state is a full
Yeah.
switch. If a
No, you,
person can do
Yeah,
that, yeah.
you're exactly right. The evidence does show that dual use is not beneficial. So,
Yeah.
especially when you're looking at toxicant levels and
Mhm.
biomarkers, you don't see the reductions with dual use that you will see when someone makes a complete switch. So we don't want to promote dual use. However, that being said, that sometimes dual use can be a step toward complete elimination of combustible tobacco. And that may be the best path forward for some patients.
Yeah. I imagine it's quite hard to just completely switch in one moment versus, work on that over time.
Yeah, it's kind of interesting because we conducted two studies with electronic cigarettes and they were with people with HIV. They were both very small studies. One of them had, I think, 40 participants. The other one had 20 participants. One of them had very high switch rates, like 37% of participants made a complete switch. And the other one had a very low rate of complete switch. Um, One of the study that had the higher rate of complete switching had flavors available, and the other only had tobacco flavor and no other
Mm.
flavors. And the literature has shown that when flavors are offered or when flavors are not offered, that you see lower rates of switching, and people tend to either switch back to combustible tobacco or there's more dual use when they're not offered the variety of flavors because people certainly like flavored electronic cigarettes.
Not to belabor my tortured analogy, but I'm not switching from a glass of wine to a glass of water, right? I'm switching to a sweet
Yeah.
flavored drink, because that tastes good and is something for me to do while I'm cooking dinner. That's really interesting. Okay, we've got some really great questions too. But I wanted to ask a couple more things and try to get to those. So what are the barriers to healthcare providers engaging with patients on this whole suite of tools, maybe with a little extra emphasis on these, kind of harm reduction tools? We've talked already about time demands and competing healthcare
Mm.
needs. You only have so much time with someone. You've got to go through X and Y, and so layering in this other thing can be hard. I think Trish, you touched on lack of knowledge and training a bit. Healthcare providers themselves carry a lot of misconceptions around, certainly around e-cigarettes and nicotine pouches. Uh, Anything else? Any other barriers? I wanted to throw one other question on a potential barrier. I was having a conversation the other day related to our event, which is next event, which is on the 23rd. Please sign up and come if you're not already signed up, where we'll be talking to people who work in harm reduction in drug use, illicit drug use, whether it's syringe services programs, whatever, about how they're starting to think about tobacco harm reduction because so many people who use drugs smoke cigarettes. And one person said something I hadn't thought of, which is that they have seen with some folks that a switch from smoking to, say, vaping is helping them with stigma, the way that they either perceive or are being treated in healthcare settings, because they don't smell like cigarettes, and
Mm.
that they feel like there is some negative treatment and assumptions made by some healthcare providers when a person comes in smelling like cigarettes versus you don't really smell like anything when you're vaping or have been vaping. So I thought I'd throw that out to you as also to see if you've experienced or thought about that at all. Anyway, barriers to healthcare providers engaging on this stuff.
So I mean, Trish, I think you're probably better poised to speak on this. But yeah, I mean, other than, we said the time demands, lack of knowledge and training, there are those, still misperceptions among HIV treatment providers about interactions between cessation medications and antiretroviral meds. Um, Trish, I will let you, if you have, I don't know if you have anything to
Yeah,
add.
no, I think we've hit on most of them that,
Hmm.
there is a lack of time. You have a 15-minute visit for a follow-up, and there are so many other competing demands on your time when you're seeing patients. They have multiple comorbidities. They may
Mhm.
have pulmonary disease, they have diabetes, they have hypertension, and there are so many, there's anxiety
Hmm.
and depression and so many other things to talk about that very often smoking or cigarettes is much lower sort of on the list of priorities. So
Hmm.
so providers don't get to
Yeah.
tobacco. I also feel like providers generally don't have good training in smoking cessation, so they don't feel
Hmm.
confident. Um, I think, one of the things that should be considered in HIV clinics is having a full team, having tobacco treatment specialists, having programs surrounding tobacco and cessation so that the provider isn't expected to do that in the 15-minute visit, but can actually make the recommendation. We know that brief advice is powerful. So
Mhm.
hearing your doctor or your healthcare provider, your nurse practitioner say to you, you really should quit smoking. It's the one, I said this a million times, it's the one thing you could do to improve your health right now. It's the single most important thing you can do to improve your health right now. So giving that kind of brief advice is so powerful that if you gave that advice and then referred to a tobacco treatment specialist within the clinic, because patients certainly like that one-stop shopping too. They don't want to go all over the place, but if they can come to their clinic and receive that counseling there, they're more
Hmm.
likely to engage in that. So I think
Got
just
it.
making things convenient for patients as well.
Yep. Another barrier kind of sitting, I don't know if it's above or under all of these things, I wanted to ask you if you have any thoughts about is we tend to see in kind of large public health oriented organizations that focus on cancer, on lung health, et cetera, on older Americans, on HIV and highly impacted populations, pretty without overstating it, pretty universally negative sentiments and statements coming out of these groups around about e-cigarettes and other nicotine products like pouches. Um, and what does that filter down to hesitancy on the part of providers? And why do we think that resistance is so firm among those groups?
Yeah, I mean, you definitely see it filtering down. I mean, you see it filtering down in the research community, which is comprised of some providers. And yeah, you see it filtering down clinically as well. It's interesting. I'm not entirely sure what explains this divide. Or
You
like
know, I
Harvard.
Yeah, no, I was going to say, I think, I have some thoughts about what the divide is about because it's such a polarizing
It is.
topic. It's amazingly polarizing. And I think what the concern is harm towards youth. So
Yep.
by making, the taxes lower on electronic cigarettes, by making flavors available, all those things lead to more concern for youth uptake of electronic
Hmm.
cigarettes.
Yes,
And,
which
that's a healthy concern.
Yeah.
But I don't think it needs to be an either or. We have alcohol on the market, very harmful for developing brains, shouldn't be used by teenagers or young, under 21. We have laws, and alcohol still readily available. So why do we try to
Including in very
restrict?
fruity flavors, right? Very fun
yes.
packaging and all of
Exactly.
that stuff. Yeah.
Exactly. But then
Interesting.
when we
Yeah.
talk about electronic cigarettes, there's this either or, it's either good or it's bad. It's very bad for youth to use electronic cigarettes and be exposed to nicotine and develop that dependence. However, you have that whole population of people who have been smoking 20 or 30 years, and
Hmm.
electronic cigarettes may be a very viable option. So I
Hmm.
think we need to get away from the either or type of thinking and think creatively about how do we keep other harmful substances out of the hands of youth. And we do
Hmm.
it, for the most part, we do it fairly well with alcohol.
Yeah.
So we need to extend that conversation to tobacco and to nicotine.
Yep. And that big spike of, several years ago of teen vaping really has come down,
Hmm.
It
which is good to
has.
see.
It
And I think
has.
that, raising the age to 21 helps because, when we were kids, you just knew someone who had an older sibling. They would go buy stuff for you, right? But bumping it up to 21 makes it a little harder. And so I think that's helpful too. I wanted to jump into our Q&A and also encourage folks, especially if we have people, participants who have lived experience themselves on this topic or who work with folks with HIV, to jump in if you're comfortable and willing, of course. So I'm going to share a couple things. So we've got Damon Jacobs, old friend of our street. In my experience, smoking can be a significant emotional relationship. It can help someone to feel connected to a partner who is no longer
Mhm.
here.
Hmm.
And so I imagine that's quite poignant generally, but also probably quite applicable in this population of people with HIV. Any thoughts on that, or we could just sort of marinate on it either way. Do you all see that in your work?
So I haven't, and truthfully, I hadn't considered that, but I can, I can certainly imagine in this population, especially.
Yeah. I've heard that anecdotally, folks saying like, this is my partner and I would have a cigarette together at the end
Mm-hmm.
of the day. Or when we'd go out dancing or whatever, we'd, smoke a cigarette together, huddled outside under the thing after, the
Hmm.
indoor smoking bans. So there's memory connected to it as well as all the,
Yeah.
physical stuff.
Yeah, I think it's very much part of the whole social network, of people who smoke, that they smoke with friends, they smoke with relatives.
Hmm.
And so in that way, it probably helps them to stay connected.
Yeah, yeah. Okay, another question from Skip. I think it's a good one. Does the stigma that some people with HIV who smoke tobacco help or hurt their motivation to stop smoking? So, do they think quitting will subject them to less stigma? Does the stigma hurt their mental health to the point they believe they are lesser or unable to to quit?
Yeah, I think there's a lot of stigma related to smoking. There's a lot of stigma related to having HIV, living with HIV. So I think it's just cumulative stigma. So when they quit, yeah, I think they probably are relieved of some of that stigma.
But might be, I guess she's also asking, is that stigma though a barrier to that self-efficacy, to that belief in the ability
Yeah, I
to do
think it
that?
Hmm.
definitely is. Yeah.
Yeah. I mean, all that just says to me, not to editorialize too much, but like this, like, just quit kind of thing that we do as a society is like, we just got to have a lot more sort of nuanced empathy and compassion for the very complex reasons that people do anything. Smoke, use drugs, lots of other things, healthy and unhealthy behaviors. And in the harm reduction mindset, meet people where they are on that without the judgment and the kind of this, horrible habit you have to stop, etc. But yeah, because if you're just adding layering onto that existing feelings of self-doubt or stigma, I can't imagine that's a helpful approach. Um, any other questions? We've got a couple minutes left here. And while we're seeing if any other questions or thoughts come in, which I'm happy to share out, wondered if either both of you have any closing thoughts that you wanted to share on the topic, links you want to drop in, calls to action if we've got practitioners, clinicians in the chat here or in the participating here of what folks could go away and think about if they want to kind of contribute to more robust and supportive atmosphere for people with HIV who smoke.
Yeah, I think my one final thought would be that in my practice, I always tried to deliver what I call person-centered care. So really finding out where the patient is, what their thoughts are, what their goals are, and not imposing my own values on someone else. Finding out what their plan is, what their hopes, dreams, and goals are, and trying to help them meet those goals, but really not imposing my own values and just working with them to deliver what I would call collaborative care, patient-centered care. So,
Hmm.
so I think that's really important, especially when you're talking about tobacco. I don't want to impose my values and say you have to quit because that's what's good for your health.
Hmm.
Provide them with the information and then help them to make the best decision for them. And continue to approach that because just because someone says, no, I'm not quitting today, doesn't mean they're going to say that tomorrow. So continue the conversation and continue to talk about it at every patient visit, every patient encounter.
And
Wonderful. Thank you.
piggybacking off of that, just trying to, keep an open mind about what tobacco treatment could look like for your patients. It doesn't necessarily have to strictly adhere to just the FDA recommended, which like that could be part of it, but be willing to think out of the box a little bit, and get creative for this group of patients who, historically have a hard time quitting.
Wonderful. Thank you. One more from Skip. Skip, I love that you're my co-pilot here. Asking, and if there's not time to talk about this, maybe we can send it in a follow-up email. But if you all know of and could share now or after the fact, any good resources available to clinicians to help them learn more about the harm reduction side of things, and how that might be a potential, thing to add to the menu, like you say, Trish.
Yeah, watch for the paper that's coming out.
Okay. We will share that out for sure.
That's addressing harm reduction.
There's also, I don't have them handy, but there's one paper that I mentioned briefly before about specifically about harm reduction among people with HIV. And then there's also another, maybe like a letter to the editor or something about uh, speaking with clinicians about e-cigarettes. So it's sort of like a precursor to what you all are. And I can find it and I can share it with you, Jessica, if you want to distribute.
Okay. Great. Thank you so much. All right. Well, we are at time. I'm super grateful to both of you. Thank you so much for the work you do. That is so important to so many people. And thank you to our participants for sticking with us. And yeah, we're just really grateful for the chance to talk about this topic. And I learned a lot. So thank you both so much.
Great. Thank you so much for inviting me. This is
Yes,
great.
thank you.
Take care. Thanks, everybody.